Okay, good afternoon, everyone. Welcome to those who are here and welcome to those who are just logging on now. We're going to get started with today's hematology deep dive session. My name is Dr. Matthew Sefdal. I am a hematologist in Vancouver, British Columbia in Canada, affiliated to the University of British Columbia and to Canadian Blood Services. And I'm very thankful that the deep dive team asked me to chair this session today, which is regarding aplastic anemia. And as the title on the slide suggests, there's going to be a focus today on transplantation of aplastic anemia, and specifically a focus on pediatric, and I'm going to add adolescent and young adult aplastic anemia, because of course in this younger age group are those patients who are most likely to need and benefit from stem cell transplantation. I like to think that aplastic anemia, there's a certain irony in being hematologists and managing aplastic anemia, because it's the condition where we're treating the absence of the organ of interest rather than a dysfunctional organ of interest. The bone marrow is usually empty, and our job is to bring it back in a timely and safe way. So I'm going to move my slide on. Just some housekeeping notes. Firstly, recordings are found on the blood.sa website under the deep dive resources. As the presentations proceed today, please add any questions or comments you have in the chat box. And I'm going to add that it is very important that you keep your own phone or computer muted to prevent background conversation and noise during the session. Please email request to be added to the mailing list to Melanie Davids. Her email is up on the slides there. With respect to the all-important CPD points, these will be automatically submitted to the HPCSA for each attendee who's registered in South Africa. So please just make sure that you are registered for this event. You would have been sent a registration link. If you have any additional CPD queries, or if you need a CPD certificate for another jurisdiction, again, please email Melanie Davids for this 1 hour CPD equivalent session. And obviously feedback is very welcome as to the content of the meeting, as well as to any content for future meetings. Big thank you to the deep dive team leader, Dr. Estelle Verberg at the University of Cape Town, who has led these wonderful sessions for many years, and very ably assisted by Gerdien Kritzinger, the National Training Coordinator, who's based in Cape Town. Today, Gerdien is not available, but she's been very ably backed up by Bridget McMillan. Thank you, Bridget. And the CPD administrator, Melanie David. So thank you to all of you. So today's agenda, there are going to be 4 approximately 15-minute presentations. One is to discuss transplant pathways in South Africa in general, with a specific focus in the second session on access to transplantation in pediatrics, using the University of Pretoria experience. We will hear 2 case presentations as well, one from colleagues at the Red Cross Children's Hospital, and one from a colleague from the University of Witwatersrand, both using pediatric examples. And then, just to advertise next week's fascinating agenda, at the deep dive session of next Monday, which will be regarding macrophages and dendritic cells from ontogeny to classification. So hopefully you'll be able to attend that as well. So I'm going to introduce the first speaker now. I think Dr. Justin du Toit is very well known to the whole South African hematology community. Justin is a clinical hematologist at the Wits Donald Gordon Academic Hospital in hematology and bone marrow transplant, and he has a specific interest in complex hematological malignancy and transplantation, with a passion for collaborative projects in best practice hematology in South Africa. And he's going to be presenting his analysis of their experience with haploidentical stem cell transplant. Very warm welcome to you, Justin. And if you could share your slides, please go ahead.
Thank you, Matt, for that kind introduction. So let's see, just going to share my screen. I hope you guys can hear me.
Yep. Yes.
Okay. Right, so today I'm going to talk about hematopoietic stem cell transplant in South Africa, and that is quite a scarce resource, and it's basically a resource that we need to kind of like embrace and develop and make sure we keep the skill. So a brief history of transplantation in South Africa. It all started in 1934 with Peter Jacobs, who performed the first hematopoietic stem cell transplantation at Curtis Hospital. This is in here, the legend himself, with I think the very famous golfer and also Trevor Manuel. In 1991, the first registry was founded by Professor Ned du Toit and Professor Peter Jacobs. And the first matched unrelated donor transplant was performed from a Belgian donor in 1997. In 2002, SACIT was founded, and in 2015, the first JC accredited stem cell transplant facility was created. And then in 2018, the second registry founded by the Sunflower Fund was then found. And then in 2021, the Sunflower Fund was incorporated into the DKMS Africa. And then if you look at the trend from 1997 to 2020, matched unrelated donor stem cell transplants have increased dramatically over time, thanks to Professor Peter Jacobs. Now, where do we stand in terms of transplants per million of the population versus the rest of the world? So this is data based on 2013. So yes, South Africa, so we do about 4 per million of the population versus the United States that do 28.23 versus Eastern Europe that do 15, and then Western Europe and the UK do 13. So focusing on transplant, so acute leukemia is the most common indication for allotransplant across the globe. If we use these global averages, we can assume that over 1,500 leukemia cases should be diagnosed per year in South Africa for those less than 30. Transplantation statistics reveal that 4 per million allotransplants were done in South Africa in 2013 versus 28 per million transplants that were done in the United States in 2018. And then 15 to 30 per million in the European Union and UK. So if we use 15 per million as a benchmark and extrapolate that number according to the age, we should be performing approximately 255 allogeneic transplants in children under the age of 15 every year, and a further 600 transplants in patients older than 14. And this is not even taking into account autologous transplants, which usually outnumber allotransplants by approximately 60 to 40. Now, if we look at the local data, this is from CAFID. These are all the unrelated, well, actually all the different types of transplants. It's autologous, match-related, match-unrelated, and haplo in 2019. You can look at the different centers. The only 2 centers that are not part of this representation here is Prof. Reinders and Professor Mignowitsky. But if you look at ACT, that's the biggest unit in the country that's very accredited. They do about 110 per year. And you can see a big proportion is autologous, then match-related, match-unrelated, and haplo. But overall, if we look at all the different units, we're not reaching that target by far. Now, why is that? So unfortunately, only a small proportion of required transplantations are done in South Africa. There's very few public and private transplant centers. I think another reason would be underdiagnosis and reporting of hematological malignancies. There is no registry, but that's work in progress. Of course, lack of infrastructure is a problem there. We have lack of isolation rooms, some HEPA filtration, positive pressure rooms. Of course, lack of nursing skill, especially in the field of hematology and transplant, and then the high cost of transplantation. So just note that only 17% of the South Africans are on a medical aid. And an allogeneic transplant would cost about 1.2 million in total, and an autologous transplant costs about $500,000. Now, other reasons could be finding suitable donors, which in our context is very challenging due to the high seroprevalence of HIV that restricts our donor pool. And then, of course, we have a very high ethnic diversity. The other factor that would be is infection prevention control, especially in the public units. CREs or carbapenem-resistant Enterobacteriaceae can affect the outcomes. And of course, there's a big shortage of hematologists in South Africa. And the curriculum actually does not even include allogeneic transplantation. So this is a quotation from Professor Bernard Lowe from UCT. So the last time a proper calculation was done, we had about 15 clinical hematologists in South Africa. Since then, a few have retired and others have opted to go and work overseas. So right now, as we speak, we have fewer than 30 clinical hematologists in the country. This was published, I think, about 2 or 3 years ago. Now, just to see why this is such a big issue in terms of finding donors for our patients is that the DK, this is based on the DKNS registry, but the the South African donor registry has fairly similar proportions. So the database represents 72% of patients that are Caucasian, 10.2% color, 10.1% Black Africans, and then 6.8% Indian or Asian donors. These are all self-identified using the official South African categories. So your probability of finding a donor if you of colored or Black African or Indian Asian origin is lower. So the real big question is, how can we solve all of this? So firstly, we need all to work together and support each other. We need to train more hematologists and nurses in the skill of transplantation. We have to be the advocates for our patients, motivate for some more infrastructure in the public sector, or even motivate for public-private partnerships. We need more research efforts, definitely to create databases and registries, reporting, and to understand our need more clearly. We have to improve the infection prevention teaching and principles, especially in the public sector. And then lastly, talking about quality management. So it often feels like a far-reaching fruit. JC accreditation, you can definitely achieve in the private units. I do think it is possible in the public sector. And JC is there, actually has been there, developed to create international standards and offer an inspection-based accreditation process in the field of transplants. It's a system that you have to put in place for the transplants to detect errors. Other high-income countries. And then, of course, I think this also needs to be part of our hematology training, this is my opinion, and not to forget that although it's a tedious process at times, that it is a safety net for our patients and our doctors, and of course, it improves patient outcomes. Now, when I went to the transplant course in Barcelona, the effect, the quality management system or basic accreditation of an outcome, it improved the outcome. This difference in outcome was observed as early as day 100 and continued up to 72 months after transplant. The effects were substantial, systematic, and clinically relevant, with an overall improvement of 10 to 15%. And the data suggests that accreditation as an indicator for quality journal work was the single most important contributing factor to the substantial improvement over time. So it is something that I think that we should achieve in most private units, and I'm hoping also one day in the public units. Right, so this was my short talk. And Mac, now we go to the next speaker. Thank you.
Thank you very much, Justin. That was a fantastic introduction to the state of transplantation in South Africa. Now, Bridget, I'm wondering if we could get the master slides up again. If that's possible.
Screen quickly.
So just a comment, quick comment to Justin there while we're getting the slides up. Oh, thank you very much. That's great, Bridget.
All right, I've given control.
No, this is fantastic. Thank you very much. I'm going to go ahead and actually introduce our next speaker then, in the hope that after all the 4 speakers, we will have plenty of time for discussion by both the speakers and the whole audience, because I'm going to suspect that there are going to be plenty of questions and comments that arise now and over the next few speakers. So a very warm welcome to Dr. David Reinders, who is a pediatrician and pediatric hematologist oncologist, and who's based at the University of Pretoria and Steve Biko Academic in Unitas Hospital. So David, for your pediatric perspective, very warm welcome, and thank you for agreeing to speak.
Great, thank you very much. I'm trying to make sure that you can, my screen has jumped around a bit, that you can see the presentation.
Yeah, it's very clear, thank you.
Yeah, okay, great. Thank you very much for the opportunity to talk today. I'm going to be, my slides are quite neutral because I'm basically going to be presenting from two separate units. So I'm going to be presenting basically the outcomes or our experience with severe aplastic anemia at Steve Biko Academic Hospital, which is an academic hospital, and then with our private practice as well, which is staffed essentially by the same group of doctors. So this is a brief overview. We'll look at the summary of Steve Biko Academic's experience. Then I'll give you a summary of the Unitas experience, looking at what the ideal world looks like and the challenges, and then the way forward. And as you can see in the picture here, sometimes what we should be is not necessarily what we are when we take our shirts off. So Steve Biko Academic Hospital is a tertiary, or some people will even refer to it as a quaternary hospital. The oncology service caters for patients coming from northern Gauteng, Mpumalanga, and parts of Limpopo province, and effectively services approximately 3 million children. We are mainly a pediatric oncology service, or started out as an oncology service. It's a 30-bed unit. 25 beds are open beds. We have 5 private isolation rooms, and 2 are set up for transplant with HEPA filtration and antechambers and the like. We admit up to the age of 18, and at the moment we are staffed by 2.5 consultants. One is a part-time consultant, and 2 rotating registrars, and a handful of skilled but burnt out nurses, which is probably about 50% of the number of staff you need to cater for just the oncology patients on their own. We do offer transplant, although unfortunately at the moment it's a type of a side project or a small hobby. We're certainly not doing it mainstream, and that's not our core business. So I've just gone back and looked at a 5-year period from 2018 to 2022. And during this period, we saw only 12 cases of severe aplastic anemia. And as I'll show a little bit later on, we should have probably been seeing about 30 cases during that time, which represents a large number of patients that are not making it to our service and are potentially dying, as I say, in the bush. We have an equal male to female ratio, and the age range was between 2 and 14 years. Of those 12 patients, 5 managed to get to ATG or to receive ATG in the form of ATGAM. And quite impressively, 3 of those patients recovered with safe counts. So not necessarily returned to normal counts, but were counts that were functional and safe. And during this time period, no patients received a transplant, which is major problem and certainly a really negative aspect about our treatment. And unfortunately, what I'm presenting here now is not necessarily how things should be done, but rather we are essentially airing our dirty laundry. But I think it's good that we talk about this and discuss what is actually happening on the ground. And I think, although I'm speaking for our unit, I think there are a lot of other units who will be experiencing very, very similar outcomes or very similar experiences. And of those 12 patients, 9 patients died, 3 with catastrophic bleeds and 6 with infections. Although not all 9 died in hospital, many of them died at home, and basically the diagnosis of how they died, or the assumption of how they died, was based on history from the family. So that, in my mind, paints a reasonably bleak picture of severe aplastic anemia in the public sector. In the private sector, it's slightly better. Unitas Hospital is a private hospital, obviously catering mainly to people who can either privately fund themselves or have access to a health funder or a medical aid. We have 14 beds, 2 of which are isolation and set up as transplant rooms. We have a very similar staff structure. That's why it's quite interesting to compare the 2 results. The consultant cover, or the oncologist cover, is identical to that at Steve Biko. The nursing staff, however, is effectively double, although it's the same number, but catering for half the number of patients. So there's a much larger group of nurses that are caring for patients. And again, we admit children there up to the age of 16. So over a similar time period there, we saw 6 cases. But what's important to understand is that Unitas probably sees about a third to a quarter of the number of patients that are seen at Steve Biko. So effectively, we would have been seeing far more cases relative to the number of patients than we're seeing in the public sector. The male to female ratio was slightly different, but again, these numbers are extremely small, so you can't really draw massive or statistical conclusions. The cases that presented, age range was slightly older, from 6 to 15. Of the 6 patients, 4 of the patients managed to receive ATG. And we were able to transplant 4 of the 6 patients. Obviously, the 2 that recovered safely didn't get to transplant. Of the 4 patients that we transplant, 1 died due to secondary engraftment failure. The background is this little guy ended up having 3 transplants. First was a matched related donor. Following the primary engraftment failure, he had a second match-related transplant from the same donor, and then a third transplant using a matched unrelated donor, and died just after engraftment. So we would have done 7 transplants for our patients. This little guy presented quite late and was in quite a bad condition, in the sense that he had very high ferritin levels and was heavily pre-transfused prior to transplant, which also didn't make him an ideal candidate. So in the ideal world, if we look at the results and the outcomes of patients with severe aplastic anemia throughout the world, the survival rate of the outcome with a matched family donor is in the region of about 87% versus 33% with a patient with immune treatment. And if we taper down from the matched family donor to matched unrelated donor or mismatched unrelated donor, or even haplo, I think going through the literature, some of the results that I found with haplos is up to 80% survival or long-term survival with those patients, which certainly would offer a massive treatment improvement or an outcome improvement if we were to look towards haplotransplants. In Europe and in Northern America, they're looking at about 2 per million children will develop severe aplastic anemia, and that's where I got my number from, up to 30 patients we should be seeing. So unless in our population we have a far lower incidence of severe aplastic anemia, we are certainly missing a large group of patients. So here's an algorithm of treatment slightly different from the adult, and this is adapted from the BSH guidelines on treatment of severe aplastic anemia. And it's pretty straightforward. I think we're all familiar with this guideline, not necessarily that we are able to follow it, but this is essentially the guideline. You establish the diagnosis, exclude inherited causes, immediately do your tissue typing. If you have a matched sibling donor, one would directly proceed to a sibling transplant. If not, then you could proceed to either giving ATGAM with cyclosporin, or consider a transplant if you have a 10-on-10 match. Failing that, or if the treatment fails, you can go on to, or the advice is to go on to a mismatched, unrelated donor. And then failing that, if that is not an option, then go on to your fourth line, which would probably be something like a second line of ATGAM, or some of the slightly more novel treatments, and finally looking towards a haplo or an umbilical transplant. So what's holding us back? Why are we not getting this right, and why are we not saving more children? And I think most of us who've treated children with aplastic anemia know that it's an incredibly soul-destroying diagnosis when a patient comes in and you know historically that your outcomes are going to be poor, and these children are going to just drag along. So I think it's something we do need to think about and come up with better strategies and ways in how we can turn this around. So some of the points that we've looked at within our own unit on how we can improve the service is looking at access to care. So in other words, streamline the pathways of referral, reducing the delay in diagnosis, and then delaying the commitment to starting treatment. And I often refer to us as procrastinating on these patients, because we kind of get to a point and we stuck, and we just don't seem to push forward. Access to transplant service, access to appropriate and essential medicines, and then finally pushing forward to awareness. So I've just taken that flow diagram and looked at a couple of the stalling points, or points where we get hooked up. And again, I'm referring specifically to our unit and things that we've sat down and identified as areas where we can improve on. So within the public sector, we often have a delay in confirming the diagnosis. Things like a chromosome fragility testing or chromosome testing takes quite a long time, and we can wait up to 4 weeks before we get the results. Tissue typing is done reasonably quickly and efficiently now by DKMS, who are supporting us with that. So often we can get our tissue typing back before we can confirm a diagnosis of severe aplastic anemia. Many of our patients come quite far away, up to 600 kilometers away from the treating center. So to get the parents and the siblings there for testing often also results in a delay, which further delays the progress on the algorithm. When it comes to performing a transplant, although we have transplanted numerous children in the public sector, we're not doing enough that it hasn't become slick and streamlined. And often it's like starting an old car each time in cold weather. Just to get it going takes time. So that's slowing us down a little bit. The capacity is a problem. We do have excellent nurses who are very comfortable with treating children in transplant, but it's just the numbers that are the problem, and especially in the background that we're managing a full oncology service as well. To take nurses out of that service to look after our transplant patients is problematic. To obtain ATGAM can be quite cumbersome. We need to motivate for the use of it and the special buyout. If we're lucky and it's on the shelf, we can give it right away. Otherwise, if it has to be bought out, we can wait up to 8 weeks to get the ATGAM. If we want to go on to perform a matched transplant or a mismatched transplant, which with the assistance of GKMS now, it has become a reality. Again, it just comes back down to gaining momentum. And then access to further medications such as Altrombopag and Campath are also problematic within the public sector. We've also seriously started thinking about moving haplos up the ladder, even as a second choice now, based on the fact that without transplant, most of our children are going to die. And if we can get a 60% survival rate using haplo, which hasn't been our experience in the private sector, that is maybe something we need to move forward and start transplanting more often. So in summary, within our unit, and again, I'm speaking purely from the Pretoria experience and how our approach is going to be with moving forward, is that it's impractical to say that in the next 5 years we're going to have a lower mortality rate and a higher survival rate. We rather need to build systems that once the patient comes into the system and they follow the algorithm, they'll get to the definitive treatment a lot quicker and a lot more efficiently. And I think that is largely why in a busy unit such as ours that is relatively poorly staffed, we can do well with regard to treating leukemia patients or any other oncology patient, is because we've got clear systems in place that a patient comes in, we make a diagnosis quickly, and then we basically just follow the recipe. And I think that's where we'd like to go with severe aplastic anemia, that we have an algorithm, a protocol, a system in place that once a patient comes in, the diagnosis is made, and then it's just a progression through the phases. And I've no doubt that we will be able to improve survival in that group of patients. But to do that, we obviously need to develop capacity. We need to somehow bolster our staff numbers. Our facilities, I've put it in green because we do have the facilities and we do have the expertise, but it's the staffing numbers and the access to specific medicines that are appropriate for children are lacking and need to be motivated. Obviously, as mentioned earlier in Justin's talk, it's expensive to transplant a patient, and that is something we need to get hospital management's mind around, that it is of value to spend that little bit of extra money. And then finally, I've mentioned as a severe aplastic anemia registry, we're going to start tracking our patients. And I think ideally, as a country, as a community, that's something we need to look towards, is setting up a formal registry so that we can see exactly what the landscape is. And then finally, I've left it right low down at the bottom of create awareness. And I've mentioned it at other meetings before that there's no point in creating awareness and looking for customers until you can offer a service. But ultimately, once our systems are in place and we can offer a good service, then we do need to go out and find the remainder of those 30 patients that we should be seeing over a 5-year period. So that's kind of just a very brief, quick snapshot of what's happening in Pretoria and how we plan to move forward. We've identified the challenges, and now we need to no longer sit there and start doing something.
David, thank you very much. That was crystal clear and very, very helpful as another introductory talk on this session about aplastic anemia. So I'll bring to your attention that there's a really nice set of comments in the chat box, some from your colleagues that I think you may want to have a look at. I do notice that Prof. Davidson from Red Cross Hospital has a comment as well. Alan, welcome. Please go ahead.
Just a bit delayed with a mouse. Geez, we got to get rid of titles, Matthew. You can call me Al if I can call you Betty. Right. I just want people to think whilst we're having this conversation about the money. The money is not a straightforward equation. Justin talked about what a transplant and allo costs in the private sector. And then if I have itemized billing and you're paying for an expensive high care bed and a whole like echelon of people, then it's a hell of an expensive process, no question. If you work in a state hospital and you consider what you spend on a patient like this compared to what you would spend in the next several to many years, depending on your level of success and your access to things like XJADE or chelators and cytokine stimulators and so on. I mean products, you know what I'm talking, GCSF and Altromapag and so on. I mean, it's actually a shed load of money. So we need to be very careful about saying things save money, but I'm not sure in the state sector where we don't have itemized billing, where the staff who cost 75% of the budget, that's 1 billion rand if you sit in Red Cross every year, are here anyway. So I'm not convinced that it's a necessarily more expensive proposition. I will say though, it does raise, I want to put this in the room, the one downstream cost of a significant mismatched donor program is a room full of chronic GVHD patients who are soul destroying apart from anything else. I mean, shame the patients are not, but managing them, and who, in terms of getting second line access to second line drugs, can be very, very difficult. So that's where I think we have to be a bit thoughtful. But anyway, thank you.
Thanks, Alan. Very, very good points about that. There is, of course, opportunity for formal economic assessments of transplants versus no transplants, although I'm going to guess that for aplastic anemia, where the likelihood of cure after a transplant is so high that the economic equations will generally be in favor of transplantation in most cases of severe aplastic anemia. Okay, I don't want to hog the floor here. Next speaker, very warm welcome to Dr. Yasmin Goga, who I had the wonderful opportunity of meeting a few months ago, is a pediatric clinical hematologist, and originally from the UK, ZN, but is currently on consultant staff at the Red Cross Children's Hospital, who's going to take us through a case that they've recently encountered. So very warm welcome, Yasmin, and thank you.
Hi, good afternoon, everybody, and thank you for the opportunity. Okay, so what I'm going to be doing is just sharing some of our experiences at Red Cross Children's Hospital. Just for context, these patients were transplanted between 2020 and 2021. Red Cross serves as the referral center for transplants for the coastal areas. So KZN, Eastern Cape, and Western Cape all refer to Red Cross. The unit has 14 beds, which it's staffed for, 17 beds at a push, and this includes the 2 transplant beds. It's currently staffed by 3 consultants. So the patients that I'm going to be taking you through are essentially snapshots of 4 patients with severe aplastic anemia, 3 that were idiopathic, and 1 with Fanconi's. So patient SH was a 7-year-old male. He was previously well, presented in January 2020 with significant bruising for a month. Of note, he was hepatitis B surface antigen positive. His surface antibody was negative, and it was noted that he was previously vaccinated. There was no dysmorphism or hepatosplenomegaly. His bone marrow aspirate and trephine confirmed a diagnosis of very severe aplastic anemia, and he was actually referred from KZN. So he had 2 breakage studies which had failed. There are logistics involved as these are sent up to Bloemfontein. His Fanconi PCR was negative, and his repeat hepatitis screen, the surface antigen initially positive, was now negative. Other viral screens and his autoimmune workup were negative, and he had a really small PNH clone of 0.17%. So let's go back 3 years. This was January 2020. We all started the year off in high spirits, and what life was pretty normal at that point. We did his workup and he was referred for a transplant to Red Cross on the basis of having a matched sibling donor. Time from diagnosis to referral for transplant was 6 weeks, and this was mid-Feb. At that point, he was scheduled for a transplant in May 2020. What happened was we had lockdown, which happened initially in March, and his treatment course and plans for transplant were actually complicated. His transplant was put on hold, and because he was so transfusion dependent, we decided that we would actually give him ATG in the interim. So his first course of ATG was given at the end of March, together with cyclosporin. Unfortunately, he had a poor response and remained transfusion dependent, requiring 9 pack cells and 6 platelet transfusions in 6 months. He was rediscussed for transplant in view of the cytopenias and ongoing febrile neutropenia, and this was 6 weeks after the ATG. So eventually we did get him to transplant. He was a matched subdonor with a bidirectional blood group mismatch. His conditioning was Campath in the bag, together with fludarabine and cyclophos, and pre-transplant, the donor required plasmapheresis. So he was actually had his day 0 infusion, the day of stem cell infusion in July 2020. His immunosuppression was with cyclosporin. In terms of his course, relatively uncomplicated. He had a febrile neutropenia on day 3, but by day 19, he had engrafted, and his cyclo was weaned from day 100. He actually remains well to this day. So that was our first patient. Second patient was patient SS, who was also referred from KZN. This was a 7-year-old male. So he was diagnosed with Fanconi's in 2016. At that point, he was asymptomatic, but he was screened as his sibling had died following Fanconi's anemia. He was referred for transplant in December 2021. At this point, he was a little bit different from the first patient. He was not transfusion dependent, having had only 2 red cell transfusions to date. But like with many other patients, he had no response to danazol. On examination, he had phenotypic features of Fanconi's with no cardiac or renal lesions. So his initial HP was 7.5, platelets were 24, white count of 3.3 with an ANC of 0.5. Bone marrow confirmed the very severe aplastic anemia. His breakage studies were positive, as was his Fanconi PCR. Viral studies were negative, and his sibling, who was a 5-year-old at the time, was a full match. So he was initially diagnosed in 2016. The donor was identified 5 years later. Now she was a 5.5-year-old sibling, referred for transplant in December 21, and scheduled for transplant in February 2022. So the timelines are pretty good. This was a matched sibling donor with matched blood groups. Conditioning was Campath in the bag, busulfan, Fludara, and rapid ATG. Day 0 was the 9th of March 2022, immune suppression with cyclosporin. Similar to the other child, pyrexia on day 3, but by day 12, he had engrafted, and he actually had an uneventful transplant, cyclo-weaned typically at day 100. He was discharged back to Maritzburg at day 127, and he remains well. So our third patient is a little bit different. So this is patient L3. The first 2 you can see were relatively, well, the second one was not transfused. The first one we struggled with in terms of his infection. So patient LD was a 9-year-old female. She was previously well, presented with fever, bruising, non-productive cough, and constitutional signs in March 2020, was not noted to have any dysmorphism, and there was no hepatosplenomegaly or lymphadenopathy. Again, her bone marrow confirmed very severe aplastic anemia. Her breakage studies for Fanconi's were negative, as were her viral and autoimmune screens, as well as her PNH screen. So here there was no donor. She was diagnosed in March of 2020. A month or say 2 months later, she received her first course of ATG and cyclo. Unfortunately, there was a poor response. So if you follow the algorithm that David put up, she went on to a second course of ATG and cyclo. And we know typically that with the second course, your response rate is even lower, possibly around 30%. So she remained transfusion dependent and required a total that we have a note of 15 red cell and 18 platelet transfusions. As expected, she developed iron overload. This was complicated by poor tolerance of X-Jade, and there was no full sibling match or matched unrelated donor. So she was actually referred for a haploidentical transplant. This haplotransplant was together with a blood group mismatch. She was conditioned using the modified Baltimore protocol. She had her day 0 on the 16th of February, 2021. Her pre-transplant ferritin was in a better space at 1,500, and she developed pyrexia at day 9. She also developed a BK virus on the urine, was treated with Polygam. So she engrafted by day 30. And this is a bit slower, which is expected in the haplo compared to the earlier engraftment, which you see with the matched related donors. Her hemoglobin remained low, dipping as low down as 5.5 to 3.5, and a little bit more of a complicated course here. By day 78, she still was requiring transfusions and had required 3 transfusions to date. Her chimerisms were checked, and this confirmed that it was 100% donor. So at that point, she was commenced on EPO. A response was seen in 2 weeks, and it was then stopped. Her cyclo was weaned, and she remained well. So in summary, a patient with a haplotransplant complicated with a urine BK virus, as well as an anemia that required a little bit of EPO to get her going. The last patient I'll be presenting is patient TD, who also had a haploidentical transplant. So again, a 10-year-old female, previously well, presented with severe pallor in March, fever in March of 2021, not dysmorphic, no hepatosplenomegaly or lymphadenopathy. What's different here is that she had a PNH clone of 10%. Breakage studies, autoimmune, and other viral screens were all negative. So this patient had several episodes of febrile neutropenia that responded to antibiotics. She was transfusion and red cell and platelet transfusion dependent, requiring transfusions every 2 to 3 weeks. And again, there was no full sibling match or matched unrelated donor. Pretty tidy timeframes from March to July. She then proceeded to a haploidentical transplant with her sister as a donor. Again, conditioned with the modified Baltimore protocol. Her day 0 was 14th of July, 2021. And unfortunately, on day 1, she had a candida from her Hickman. By day 12, the Hickman was fractured and she required a new line. At day 33, she had skin GVHD, which was grade 1. She was commenced on Dovate and settled on that. So she had white cell count and platelet engraftment by day 22. And then by day 40, her viral load for CMV started to go up and she required ganciclovir for 4 weeks. Her cyclo was weaned and eventually stopped at the end of November, so over 5 months, and she actually remains well as well. So in summary, I've presented 4 patients with severe aplastic anemia, 3 that were idiopathic and 1 with Fanconi's. Of these, 2 were matched sibling donor transplants and 2 were haplotransplants. What I didn't include was a further patient who we attempted to transplant this year, who was a matched unrelated donor, unfortunately developed ATG hypersensitivity and ended up with multi-organ failure and demised. So as per David, the algorithm is actually very clear. Severe aplastic anemia in peds, if you have a matched sibling donor, you transplant ASAP. If there's no donor, then you would go down the road of ATG. And I suppose for me, the debate really is whether we should consider a second course of ATG, or actually whether we should be referring for a haplo before our patients become severely iron overloaded and develop other antibodies. Having had experience both as being as somebody referring to Red Cross and now being at Red Cross, I think I can speak to some of the greater barriers to transplant. And these include exclusion of Fanconi's anemia, difficulties with lab turnaround times, breakage studies, also difficulties in terms of getting the family to present for testing and donor availability, even when there may be a donor on the registries. In terms of HLA typing, our turnaround times have definitely improved, but this is still hampered by the availability of reagents from time to time. And then other barriers include transplant bed availability, and let us not forget what COVID did. Other considerations that we do need to note is drug availability and consumables. And I think we need to be clear in terms of the entry and exit criteria for transplant, and actually be more aggressive in terms of doing the high-res and the NGS HLA typing and search up front. What's also important is preparation of the patient and family pre-transplant from the referring hospital, physician and nurse education all around, and then actually starting to tackle some of the cultural beliefs which may be potential barriers. But I think also from having to coordinate this list, there are many processes involved, and these need to actually become streamlined, and we all need to have a clear understanding of what the processes are. I think this will alleviate many delays. And the last thing for consideration is to try and decrease pressure on the units, the transplant units, whether with time we can actually look back to earlier referral to base once the protocols are in place. So thank you, and I hope that's been clear.
Yasmin, that was fantastic. It was more than clear. Thank you very much. Really nice selection of cases and concluding comments from you and your team. I think let's move on, because then we will have time for good discussion towards the end of the session. So we're going to move northwards now and hear a presentation from Dr. Angini Mori. I hope I pronounced your name right. Angini is a new fellow in pediatric oncology at Charlotte Masheshe Hospital, and he is a pediatrician, specializing now in pediatric hematology and oncology, and has also completed a postgraduate diploma in pediatric palliative care at UCT. So he is representing the experience at Charlotte Masheshe Hospital and University of Witwatersrand. So welcome, Angini. And please go ahead when you're ready. Hopefully your volume is all, you're unmuted, etc.
Is it sharing?
Yes, it's good now, but maybe put it in presentation mode. Perfect. Thank you. That's great.
Okay. So good afternoon, everyone, and thank you for the opportunity today to let me present about a case that we had in the hospital recently. So as you said, I'm one of the new fellows at Charlotte Masheshe Johannesburg Academic Hospital. And I will be telling you about our journey as a team, working with one of the children we follow up with severe aplastic anemia, and how we prepared her for allogenic stem cell transplant. So it was the first such intervention at the hospital in over 10 years, and we all learned a lot along the process. So I will briefly go through the patient's background, outline the workup we carried out pre-finalizing her conditioning regimen, and then talk about the transplant itself and the monitoring thereafter. So Miss KM is an almost 15-year-old teenager at the end of this month, and she acknowledges that it is by far the best birthday gift that she could get. So she was born in South Africa from South African parents and stays in Joburg. She was diagnosed with severe aplastic anemia in June 2021 at the age of 12 years and 8 months, and has been following up with us at the hospital since then. On further history, she's had an uneventful perinatal and medical history, was not previously on any medication, and she's currently in grade 8 and doing okay at school. And if you see on your right at the genogram, so the parents were traditionally married, now separated, with heavy conflict between them. And this has been the cause of tension in family discussion thereafter. Miss KM has 2 younger siblings of 8 and 6, and the youngest sibling of 6 was the subsequent donor. So in June 2021, Miss KM, who loves soccer and is very fit, then presented with symptomatic anemia and generalized ecchymosis at another hospital in Johannesburg. She was found to be pancytopenic with a white cell count of 2.77, neutrophil of 0.17, hemoglobin of 3.3, and the platelets of 10. And she received blood and platelet transfusion then. So bone marrow was done, and it was aparticulate and hypocellular. And she was subsequently referred to Joburg Gen Hospital a couple of days later. So when she presented to our unit, on examination, she was found to be severely underweight for age, moderately stunted and severely wasted. Currently, her anthropometry is much better. She's not stunted or wasted. She did not have any dysmorphic features of note, and a repeat bone marrow done at that point showed markedly hypocellular fragments for age with virtually absent megakaryocytes, poorly represented erythropoiesis and granular poiesis, and there were no cytogenic abnormalities. So her autoimmune screen was negative, and the screen for viruses such as hepatitis A, B, and C, parvovirus, EBV, CMV, and HIV were negative. And in terms of Fanconi gene, so it was actually the FANC-G gene which was done and which was negative. The CMV viral load and was also tested, and it was lower than detectable limit. And an EBV viral load was actually done, and it was found to be elevated. So the EBV viral load was actually 12,820. And on consulting the literature, we decided to treat Miss KM with acyclovir for 1 year, as per other case reports which had been done worldwide. As you can see from the results, the viral load then dropped to lower than detectable limit and stayed at that level ever since. So acyclovir was stopped a year later. And at that point, we did have capacity to do transplant, but it hadn't been done in many, many years. And there was also no ATG which was available to us. This is a slide of just the number of transfusions received by Miss KM before her transplant. So as you can see, she had received almost 30 units of red cells and 8 units of platelets in a 2-year period. She was started on deferasirox XJ, the oral iron chelator, which has helped towards reducing her ferritin level. The discussion about having a date on which the transplant would happen started at the beginning of July. And we had already had in the meantime the HLA typing of Miss KM and her youngest 6-year-old sibling, which showed a match. So the typing was done at the South African National Blood Services and at DKMS, and chimerism testing also was done. And there was 2 different teams serving as advocacy for the donor and for the recipient to try minimize coercion. As alluded to, the relationship was quite conflictual between both parents, and that has often had to be addressed in subsequent visits. This is just a list of all the workup that we did. And I would just like to point out that the baseline GFR was 59 on nuclear GFR, And so we had to speak to the nephrologist also just to find whether there was any potential nephrotoxic risk thereafter. So it was indeed a multidisciplinary team involvement with getting expertise from a lot of people to ensure that the transplant would happen as smoothly as possible. So under the coordination of Prof. Hill here at Joburg Gen, we also got help from Dr. Dutoit at Donald Gordon and Dr. Nkabi from Nelson Mandela Hospital. The pharmacist also had to be consulted to make sure that we have all the drugs that we'll get to later. And as alluded to by the previous speakers, training of nurses is definitely needed, and it was done in the clinic and in the ward here. We also had to prepare a room to welcome someone post-transplant, and we received a portable HEPA filter from Dr. Dutoit. The room did not have any negative pressure or antechamber or laminar flow as ideally it should be. The pediatric surgeon also was consulted for Quinton line insertion and for Hickman line. And we also booked a bed at the Nelson Mandela Hospital in case any issues were to arise. So the aim was to get a bone marrow harvest from the donor, but she's only 6 years old and weighed 15 kilos. So we decided it would be much safer to harvest stem cells from her. And she received filgrastim 5 days before the harvest, and there were no complications. So that's just part of the conditioning regimen. So we had 2 bags which were collected. The first bag was actually what had Bacillus species in it and was not used. We only used 1 bag of stem cells, which had about 3 × 10⁶ of CD34 cells. Miss KM was admitted 7 days before the infusion of stem cells. And on going through the literature, we decided to use fludarabine, cyclophos, and ATG rabbit as a conditioning regimen. So as you can see, fludarabine was given from day -5 to -2, cyclophos from -3 to -2 with Mesna, and ATG rabbit on -3 to -1. Odanzetron and haloperidol were used as antiemetic, and cyclosporin was started at day -3 as prophylaxis for graft versus host disease. And there was no issues noted prior to the infusion. After the infusion of stem cells, methotrexate was given at days 1, 3, 6, and 11 as prophylaxis for GVHD. And the nurses and doctors were educated about very strict monitoring of vitals while also respecting strict burial nursing. We thoroughly examined Miss KM to look for any signs of acute GVHD, check for any fluid overload by recording the input and output and watching the trend in her abdominal circumference and weight. So the site of Hickman line was also always inspected to look for any infection and or any signs of GVHD. So bloods were also done on a regular basis with special consideration about EBV viral load, CMV viral load, and cyclosporin level. So those are some of the highlighted results which I put in this table. So as you can see, there was not a very much appreciable increase in total white cells by day 13, which could have been by us using only 3 × 10⁶ of CD34 cells, which then made us use filgrastim. And this led to a significant increase in white cells and neutrophils by day 19. So engraftment happened by day 21, and the patient was discharged at 4 weeks post-infusion. So she's moved to a CHOC house, which is close to the hospital and where she can be swiftly transferred back to the hospital if there's any issues. On her last checkup, there's actually her results from last Friday on the column on your right. So as you can see, the counts are still good. And what we can also notice is during her hospital stay between the infusion and discharge, Miss KM had required 3 red cell units and 3 units of platelets, but subsequently after her discharge hasn't required any blood transfusion. And she also has not picked up any infection during her hospital stay or discharge. So she now comes on Mondays, Wednesdays, and Fridays for visits. The Hickman line has been removed. Her EBV and CMV viral load have been lower than detectable limit. She has had chimerism testing done last week, and we are adjusting the cyclosporin level based on her levels. Her renal function also has improved significantly over the last few days. and Miss Claire and her family are very happy, and this transplant could not have been done without all the people involved at different stages. And we have already started discussions and the workup of the next child with aplastic anemia, and we are looking forward to many more transplants to come. Thank you very much. That's all from me.
Mangiri, thank you very much. That was really a wonderful and very thorough review of this patient's treatment course. I do want to commend you on how you summarized the process of clinical care, which was methodical in an attempt to ensure that this patient had a smooth peri-transplant and post-transplant course. So well done. Not just because of the outcome of this patient, but because of your approach to the care of this patient. So well done to the whole team. I just want to make then a couple of comments so that we can have a group discussion. And if you could either let me know that you want to make a comment by putting your virtual hand up, or by leaving a comment in the meeting chat. I'm well aware that there are several experts in this audience in the field of transplantation and aplastic anemia and bone marrow failure states in general. So would love to hear your comments and questions. So I'll hold back now and see if there are any questions. I do want to maybe, while you're just thinking about some questions, want to bring to your attention the fact that Professor Malherbe from Bloemfontein did bring to our attention that there is relative ease in HLA typing of patients and families by virtue of assistance from DKMS. So which makes the process both more efficient and less expensive, which is good to hear.
Matt, all I can say is that what has been presented is so compelling and so real. It was presented so simply and plainly that I actually don't know what to say. I want to say, you know, like David said, what do we do next? That's how I feel. Of course, there's wonderful things to discuss. We can debate a lot of stuff. I see that I think Alan has not, has decided not to bring too much Fanconi, Alan and Yasmin into the conversation, because that obviously is a bit broader. But I would be intrigued to know what the pediatricians, you know, I'm looking to Yasmin, Alan, David, what they would think. I think, as I say, compellingly it has been presented, but for example, I would not give a second course of ATG, and I would be interested to know if other pediatricians have had success. I have never thought that it helps. I also want to draw the attention to the blood given to this transplant at Charlotte Maxeke, which was absolute, I think, 3-4 units in total of red cells and platelets. And the difference it is compared to the XJ the patient had to receive beforehand and chronic transfusion. It's really compelling that it is health economics makes sense. We must simply find out how. But the question is obviously, no, does ATG have to give it are we going to still believe that it should be given? Are we ever going to give it a second time if there is a haplo donor? That's the practical question. If there's a haplo donor or there's a mud donor, perhaps those are more difficult choices. Or are we going to go, you know, when will be the time that we will actually believe that a mud could be an upfront option? That's just my question to the pediatricians. I know it's a difficult question, but as I say, the rest of the data is so compelling that we actually don't even have to discuss it. We can just say, yes, it's true. So I don't know,
Thanks,
Alan, do you
Estelle.
want, yeah, do we want to
Thanks, Estelle.
answer?
Very, very good points. I've got a question for anyone about first-line immune suppression, both from the public sector as well as from the private practice sector. Through certainly North America and likely Europe now, the first-line immunosuppressive therapy without transplant, if given, in other words, if there's a decision to not offer a transplant first line, it would normally now include frontline L-Trombopag. I don't know whether that is even available, but I would be interested to hear about access to and enthusiasm about L-Trombopag up front.
Matthew, can I divert back for a second? So I was like waiting. I just want to grapple with the issue is with the big questions. It's interesting the way we pitch things. So Estelle says, if there's a haplo donor. Now, I mean, that's the truth, right? I mean, that's the essence of this issue, is in a where you have a narrow pipeline, where you're hearing the numbers. We're doing, if we're lucky, between the centers. And if I include Nick, maybe it's 50. I doubt it's 50. It's probably 20. David and I spoke the other day, maybe 35 kids a year, maybe, if we're lucky, for a 250, which we went round the houses on the paper that Candace Hendricks wrote, the original one, not the endpoint submission. The guys were talking about 250. David and I wondered whether it wasn't closer to 150, but it doesn't matter. It's a fraction of the total. And so in a sense, we have to consider, you can decide that you're going to do that, but what's your pipeline going to allow? And the biggest issue for me, and Estelle, I'm going to bash this drum again because you've bashed it with me, is we need to do the match sub donors first. And Estelle and I have said on a number of occasions in a number of fora that we don't believe that all the match sub, in other words, all the people with this diagnosis who've got an available match sub, are being properly referred through the system and are being worked up. We keep getting these kids after 20 units of blood. You know, somebody comes out of the woodwork, somebody goes, oh gosh, let's do some tissue typing. Often, I mean, they may be ATG naive, they may not be. I'll pick up on that just in a second. But so, I mean, it's not like, you can see, as a center, we do haplos in these cases. I certainly wouldn't do a haplo before ATG. It's debatable whether we would have to have L-Trombopag. It's tricky to get hold of. And I mean, most of us in PEDS have seen some successes with immunosuppressive therapy. There's a couple of guys in the community, including a transplanter out in your neck of the woods, Kirk Schultz. You know Kirk. And I mean, Kirk's got quite a strong feeling that pure aplastic anemia, where you don't have the sense that there's any kind of, like, you know, underlying mischief, that it really is an autoimmune disease and you can reset it. And so we have patients in durable, like complete remissions, years out after ATG. So if I had a perfect donor, yeah, I would graft. But if not, I wouldn't be worried about doing ATG. And that's why. So my big thing is, I think we need to start with the winners, the guys that engraft on day 9, the guys that don't even need antibiotics. We've had a couple. And when I say we, I mean the whole complex, going back to when we did transplants together, Nick was doing the private stuff and the state stuff at Criticia. So, you know, how to sort that out, I don't know. Recently, a couple of people in a forum, Estelle, you must speak to this, have said, no, rubbish, everyone's being referred. And I'm still not sure. I'm not sure about that. But I think that's a group we have to focus on, is you know, those patients with good matched grafts, and do those. And then for sure, if somebody fails immunosuppressive therapy, then yes, you know, and then you might consider a haplo. I would agree that going a second time with ATCAM is probably like quixotic, and certainly using rabbit, I think, is generally agreed now that rabbit's not going to do anything. So, anyway, those are my scratchings. Thanks for listening.
Thanks, Alan.
Alan, how do you feel about matched unrelated? Just wanted where would you place that?
Matched, no, that's fine. Matched, just not mismatched transplants without trying IST. That's my feeling.
Okay, but then we have a lot of patients to transplant, I think. Yeah, and the question is obviously where and how, but as you said, the sooner we do it, the less complications. And I think that's perhaps the message that everybody should hear, that there is, and that, I don't know if Matt wants to speak to that. I mean, as Alan said, 20 units, often much more. That does have an effect on outcome, and it also means that XJ needs to be used, which is one of the most costly drugs that we use. I don't know what both of you think about that.
So I see there's a comment from Yasmin, so please go ahead.
Hi. So in terms of our approach, transplant space has typically been limited, and I think we need to be very aware of that. You need to choose these patients well, because you are battling against other patients with malignancies. So it's really a question of who's going to get access to those 2 beds. We've done immunosuppression at Albert Luthuli for many years before that. And I would say probably 70 to 80% of those patients would have responded to the first course. By the time I get to the second course, I know we are in trouble. So over the years, what has changed is your turnaround time for HLA typing and as well as your access to things like XJ. So I would still stick to saying, if it's a patient who is not overtly septic up front, who's not requiring massive transfusions up front, go with the immunosuppression first. My reservation is for those patients who are extremely transfusion dependent, who are constantly septic. Those are the patients who you're going to lose because you don't have time for that immune suppression to work. So if you give the first course of ATG in those patients, we should be waiting 3 months. But if you look at the first patient I presented, we really struggled with his infection. So the moment he had something that was a lull in the infection, or his infection was controlled, that's a time you would need to consider, and you would need to consider those patients for haplotransplants. I think we must not forget that transplant is not a benign procedure. Patients are lost. Patients have significant morbidity if it goes badly. And therefore, I think with immunosuppression, you give that a chance first if you don't have a donor. And then if there's no response to that, then you consider a haplo. But I would be very reluctant to put up haplos for everybody up front. I think the second thing is that patients, or rather physicians, need to have an aggressive response. So when your patient is seen, part of your workup right at the beginning is to send off HLA typing and to do that registry search up front. That has to be done right at the beginning. So those are my 2 comments.
Thanks, Yasmin. And certainly a reminder that following internationally published guidelines do need tailoring to whichever resources are available to you at the time. And that's not necessarily just the upfront resources for admission to hospital and or HLA typing, etc., but also the sort of follow-up that's going to be needed in the medium and long term for these patients. I just want to touch on the chat box conversation because of the quite pertinent question that was asked by Jacques Malherbe, and perhaps the discussants, either Jacques or Alan, might want to talk about this a little bit as to whether the presence of detectable PNH, a PNH clone, in somebody with aplastic anemia would influence the decision to proceed to immune suppression therapy versus a transplant. So that's quite an interesting point, because as part of a standard workup for aplastic anemia, a search for PNH is generally considered a standard activity. Even if there's no clinical signs of PNH, there may be PNH clones that are detectable. So Jacques or Alan, are you willing to chat about this a little bit more?
Thanks, Matthew. Yeah, I was just thinking about in our setting. I mean, I think where transplant is freely available and easily accessible, I mean, that shouldn't impact the decision to transplant. I mean, if a donor is available, the patient should still get a transplant. But I was just wondering, in our setting, as Yasmin mentioned, limited beds and resources, and I mean, other issues, patients very far from transplant centers, and other barriers to transplant, maybe poor support and so forth, where if you have patients, multiple patients that you need to choose from, if the aplastic with a small PNH clone, which would predict for a better response to immunosuppression, you may consider in that setting to first go for the immunosuppression. I just sort of wondered about if anybody's ever sort of applied that principle. I mean, the converse, if you read the literature, the converse is, the presence of PNH clone makes you much more confident in your diagnosis of aplastic anemia. You would want to go for the transplant. So it's a bit of coming a bit from left field, but just thinking in our resource limited setting.
Thanks, Jacques.
Yeah, and from my side, it's interesting how one comes at this from different perspectives, but we've had a couple of kids over the years, and all of them have had, so interesting, one I remember very particularly came from the Eastern Cape with ostensibly when I say that, I don't mean it pejoratively, with a complete workup, but in the paperwork it said PNH negative, you know, and the guys, the fellows had got all the results together and so on, and he was in the ward waiting. So we were already heading to transplant. The decision had been made. He was labeled aplastic, and he just consumed red cells in particular whilst he was waiting, to an extent that made us we were sitting mulling over this. It clearly wasn't immune, so it wasn't immune, it wasn't sort of autoimmune. And it was one of our pathologists who said, guys, I mean, where's the PNH result? And then we looked, high and low, and then we repeated it, and then he had a clone. So the few patients that we've seen like that have, for me, they've been disease more than just a signature. So, I mean, what's a number? How big? And I would be inclined to graft rather than use immune suppression when if it's in the sense of diagnosis more than just a clone. But maybe if there's a very small clone, gosh, I don't know. What do you think, Matthew?
Yeah, so I think that the PNH diagnosis to me is mostly relevant in terms of reassuring me that the diagnosis is most likely fitting with idiopathic aplastic anemia, and of course then with a concomitant PNH clone. The absence of a PNH clone, especially in children and young adults, just is a prompt to think that we may be dealing with a different cause of bone marrow failure. And of course, in the younger people, one needs to think about inherited bone marrow failure states, where immunosuppression is obviously much less likely, if not impossible, to result in a positive outcome. So I see it mostly just sort of as an indication to say, well, you're probably right. This is idiopathic and likely autoimmune disease, but still base the treatment decisions based on the severity of the disease of the aplastic anemia and donor availability. So I just want to make a quick comment on the decision for upfront transplantation. So you know, for those of you who've spent time in either Europe or North America, or perhaps Australia and New Zealand, you'll know that transplantation programs function with quite deep administrative infrastructure, with the ability to search for donors on quite a smooth and predictable pathway. And often you can delegate that activity to coordinators and technicians who do the job so incredibly rapidly. And that influences outcome. If you can head to a sibling matched transplant within, you know, 2 to 3 weeks of your diagnosis, and even in my situation, I have been able to head to a full matched unrelated donor transplant within a month of initial diagnosis. That is not surprisingly going to be associated with wonderful outcomes, because these patients are minimally transfused and often afebrile at the time of transplant. So I think that for those centers that want to offer transplant, it's good to refer to transplant programs that can have that sort of administrative infrastructure to get the transplant going fast. So it just goes back to David's point: early referral and infrastructure is incredibly important. And this is the hallmark disease where transplantation results in good outcomes. You don't have to rely on a graft versus leukemia effect. There's no benefit to graft versus host disease. It's just getting a new organ in place. But it has to happen fast and efficiently with all the right infrastructure. So that's my quick speech on the benefits of transplantation for this admittedly relatively rare diagnosis. There was a comment here on ease of access or not to equine ATG from Charlene Parasnath. Does anyone want to comment on access to equine ATG?
Hi, Matt. It's Charlene. I asked my colleagues a question because the supplier in South Africa was not able to supply. So I was just checking if anyone has been successful in finding an alternative supplier, and if so, if they could drop it in the chat group. So because we have a whole host of patients, our list is sitting at over 10 patients at the moment in our unit waiting for ATG.
Charlene, while others are considering an answer, does that imply that access to rabbit ATG is better?
No, so equine ATG was the first line in our unit, and we've used it for a long time. However, when the stock of it has been very low in the country since the beginning of the year. We've used rabbit in one or two patients, I'm not certain, but that is also a problem because it's not on the essential, it's not, I can't say it's on the essential medicines list, but our pharmacy committee at head office actually prefers us to use the equine, and we also favor the use of equine. So and obviously in our center, if there's a matched sibling, transplant is the first option, and we actually type every patient as soon as we receive the patient in our clinic. So that's just the way we do it. So if no sibling, then equine. And if they fail equine and still no transplant option, then we would try rabbit ATG. Oh, and also unrelated, if we can find an unrelated donor, then we would do that. So in fact, we're doing our first one this year.
Oh, that's great. Thank you. Okay, I'm going to just bring up another question to the various transplanters in this group as to on the assumption that there's been a decision to move to a related donor transplant. So this is mostly going to be a family-related donor transplant. The one case that we heard about, the source of cells had been peripheral blood stem cells. So are there approaches, preferences, and traditions about using bone marrow versus peripheral blood for either for children or the adults?
I'll just jump in there I put my hand up, but I'll just jump in. We generally prefer marrow for our patients, even for the malignant cases, especially if we're using a sibling. We've really tried hard to only harvest siblings with a marrow, but I think it's becoming more complicated, more expensive to get hold of the collection bags. So I think that's kind of slowed things down a little bit in terms of the number of patients that we can give marrow or offer marrow transplants to.
Just
Thanks, David. Estelle.
Quick word from the adult transplanters, but also from Red Cross. I mean, Alan may have a different opinion. We simply do not have the personnel, literally, to go into the theatre. I mean, I did these kind of collections when I was a junior consultant in Belgium. It's incredibly time consuming. And as David said, the bags are difficult to get. So we only use bone marrow for SCT kids. And apart from that, we just do not have the ability. So I think it's not always clear how much better it is to use bone marrow. I know in peds it is preferred, but is it so, how much better? Less GVHD? I think I've seen conflicting data on the long-term effect, yes or no. I don't know what you think, or Justin. I don't know.
Matt, so I can just make a comment on the patient that was transplanted at Charlotte. So initially we wanted to do bone marrow collection because I think that is the preferred source in the world of aplastic anemia. But the donor was half the size of the recipient. So we decided to opt for peripheral blood stem cells. And the reason why CAMPATH was not utilized in the diet is because we had to actually it was planned ahead of time that we collect the donor. We were not even sure how much, if we're going to be successful collecting enough stem cells, although we did collect more than enough peripheral blood stem cells. But we couldn't actually add CAMPATH to the bag because it was also cryopreserved cells. But the regime that we used so far there's been no signs of any graft versus host disease. So just can be very grateful for that. But yeah, but if I do think if it's possible, you should use bone marrow, but I think in the public units that will be quite challenging. So the peripheral blood stem cells with CAMPATH is probably better.
Thanks, Justin and Estelle. I noticed that we've just gone a few minutes over time. So I want to just wrap up by saying that this was a nice presentation that highlighted why diagnostic and treatment approaches in your jurisdiction may not always align with international guidelines and expectations based on differences in the patients, differences in the resources that you have, and why these deep dive sessions are so important, how they provoke thought and action and new approaches across the country. So I want to just extend a big thank you to both the organizers, so this is Blood SA and the University of Cape Town, and the 4 speakers today from institutions from across the country who have, as usual, presented world-class data and presentations. So it's always an honor to be able to be part of these. And thank you very, very much for everyone who took the time out of their day to listen and participate.
Thank you very much, Matt. We're so thankful. It's wonderful to have your oversight and your leadership in such a meeting. And thank you, Alan and team from Red Cross. And thank you to all the colleagues. I hope that we will now have some more meetings on aplastic anemia across South Africa. And David Reinders has already shown us what a guideline could look like. So let's see what we can do. So, thank you to everybody.
All the best. Have a good evening, everyone. Thanks.
Thank you, everyone. Bye.
Thanks, everyone. Bye-bye.
Thank you, folks.
Thank you. Bye.